Bismillahirrahmanirrahim. In our last lecture, we discussed the diarrhea that is associated with malabsorption. And we discussed the two very important diseases, the celiac disease, which is an immune-mediated disorder associated with malabsorption, and the other disease is the cystic fibrosis, which is a genetic and autosomal recessive inherited disease that is also associated with malabsorption. And the malabsorption in cystic fibrosis is due to pancreatic insufficiency, which is caused by the blockage of the pancreatic duct by the thick secretions. Today we discuss the lactose intolerance, a common disorder. We will discuss irritable bowel syndrome, and we will discuss the tropical sprue or tropical enteropathy, and we will also discuss a rare genetic condition, A beta lipoproteinemia, and we will also discuss microscopic colitis. Before we discuss lactose intolerance, let us have a brief review of the carbohydrates digestion. We take mainly carbohydrates in the form of starches, which are polysaccharides. The digestion of the polysaccharides or starches start in the mouth by mechanical digestion and addition of the salivary amylase. The polysaccharides are partially broken down into disaccharides. Then in the small intestine, this is the pancreatic amylase, which will break down the polysaccharides into the monosaccharides and disaccharides, and in this form the carbohydrates are absorbed, and we say that the disaccharides and monosaccharides is the absorbable forms of the carbohydrates. By the action of salivary amylases, the polysaccharides are broken down into glucose, which is a monosaccharide readily available for absorption and to be used by the body in oxidative phosphorylation for energy. And the two disaccharides, one is sucrose, commonly known as the table sugar, and the other is lactose, commonly known as the milk sugar. The sucrose is broken down by the enzyme sucrase into glucose and fructose. Fructose is further broken down in the body into glucose. And the milk sugar or lactose, which is a disaccharide, it is broken down by the enzyme lactase into glucose and galactose. And galactose again is further broken down into glucose in the body. And finally, we get the glucose as the major source of energy, which will enter the oxidative phosphorylation to yield energy. So here in lactose intolerance, the problem is with the enzyme lactase. Normally we can see on the left side that the lactose is broken down into glucose and galactose by the enzyme lactase. But if this enzyme is deficient or if this enzyme is missing, what happens? The lactose is not digested and it remains in the intestine. Particularly when this unabsorbed and undigested lactose enters into the small intestine where the normal flora, bacterial flora is present, and this bacterial flora will cause fermentation of the lactose. Lactose fermentation will result in the production of gases like carbon dioxide, hydrogen and methane, and these gases, they will cause abdominal distension flatulence, and feeling of a discomfort and indigestion. Moreover, by the action of the large intestinal bacteria, which is the normal flora, the breakdown of fats will result in the production of short chain fatty acids, acetate, butyrate. So what happens that the presence of the lactose itself, the presence of the short chain fatty acids, they will produce an osmotic pressure in the large intestine, and increase osmotic pressure in the large intestine as compared to the pressure in the surrounding interstitial tissue, it will be higher. And what happens that this increased or higher osmotic pressure will pull water from the interstitial tissue into the large intestine, and this will result in diarrhea that is known as the osmotic diarrhea. We divide diarrhea into secretory diarrhea, exudative diarrhea, osmotic diarrhea, malabsorptive diarrhea. So here what type of diarrhea occurs? The osmotic diarrhea occurs. Normally, a newborn baby is totally dependent on milk, on his or her feeds. So at that time, the gene that codes for the enzyme lactase, it is highly expressed at the intestinal enterocytes. And this happens by a type of natural selection where large amounts of lactase are required for the to break down the lactose into glucose and galactose. Later on, when a child grows and other foods in addition to milk are added to his food, the need for lactase enzyme decreases, and this results in down regulation of the gene that encodes lactase. In these cases, if the lactase enzyme is severely deficient, since the milk is a part of the food of the child, so it may give rise to mild type of symptoms. Some people in some parts of the world, they take milk until their adult life, and milk is their major food. So in those people, the expression of the gene coding lactase is persistently expressed, and they are known to be lactase persistent. The other type of the lactose intolerance, which is the severe form, and that is the congenital form in which the gene coding lactate is mutated. This type of genetic disorder is inherited by through an autosomal recessive pattern, and it is the severe form of the lactose intolerance. And normally, it is a common practice that babies who suffer from persistent diarrhea when they are breastfeeding or when they are on milk totally in their food, uh, if it is suspected that they may be having lactose intolerance, their diet is changed into lactose free milk, and a variety is available in the market, the lactose free milk. And if the child gets relieved, if his diarrhea and gastrointestinal disorders and symptoms are relieved by taking a lactose free milk, we can say that this is an indication that the child suffers from lactose intolerance. Whatsoever, but the deficiency or lacking of the enzyme lactase will result in failure to break down the lactose into its disaccharides. Now, the presence of the unabsorbed lactose, which when enters the large intestine, that is fermented by the normal flora or bacteria present in the large intestine. So what happens that the lactose, its fermentation products and short chain fatty acids, they will induce an osmotic diarrhea, and additionally they suffer from abdominal distension, bloating, cramps, and other gastrointestinal disorders like uh, inability to digest certain foods, and uh, flatulence, abdominal pain, indigestion, and cramps. How do we diagnose lactose intolerance? We know that the unabsorbed lactose in the large intestine is fermented by the bacteria or normal flora present in the large intestine, and the fermentation process results in the production of gases like hydrogen gas, carbon dioxide gas, and methane. Now, the hydrogen gas produced is absorbed into the blood and is carried into the lungs from where it is exhaled. And we have a technique known as the gas chromatography technique, which can measure the presence of hydrogen gas in the expired air. So we can use the gas chromatographic technique, and if the amount of hydrogen exhaled is greater than the defined or reference values, we can say that this is due to lactose intolerance. Moreover, a very simple test in which we give a heavy dose of the lactose to the person, and giving him lactose before the ingestion of the lactose, we measure the blood glucose level, blood sugar level. Normally, if the patient is not suffering from lactose intolerance, what happens that the lactose will be digested by the enzyme lactase and converted into glucose and galactose. The galactose is also in the body converted into glucose, and normally we expect that there will be a rise in the blood glucose level. We compare the blood glucose level before the ingestion of the lactose and blood glucose level after ingestion of the lactose. And if there is no increase or no rise in the glucose concentration of the blood, we can say that the person is suffering from the lactose intolerance. Tropical sprue is a type of enteropathy, intestinal associated disorder, that is commonly seen in countries that are located on the tropics. And those countries also include Pakistan. It is said that certain bacteria like Klebsiella, E. coli, and Enterobacter, they are endemic in these areas, because these are developing countries and the hygienic conditions for food and water are not so very efficient. So what happens that these pathogenic bacteria, they overgrow the population of the normal flora of the intestines, and the person suffers from repeated bouts of diarrhea. Particularly those children that have suffered from diarrhea, repeated bouts of diarrhea in the first 2 or 3 years of life, they are more at risk of developing the environmental enteropathy. So in tropical sprue or tropical enteropathy, what happens that the repeated bouts of gastroenteritis and infections in the intestine put the bowel in a state of chronic inflammatory condition or chronic inflammation. And as I said, it is believed that this may result from chronic exposure to contaminated food and water, and moreover, in the developing countries, malnutrition is also a problem. So, in combination with malnutrition and repeated exposure to infections, the normal flora of the intestine is disturbed because these bacteria produce toxins. And these toxins put the bowel in a state of chronic inflammation. And these toxins may damage the intestinal villi, and the normally elongated intestinal villi, they are turned into flattened villi. The villi becomes flattened, the intestinal absorptive cells are damaged, and it results in a type of subclinical disease which is associated with severe malabsorption. For example, the absorption of micronutrients, iron, B12, folate, which may result in severe anemia. These patients suffer from abdominal pain, diarrhea, fatigue. Ultimately, they will lose weight, and sometimes they may suffer from severe dehydration due to poor absorption of water, and deficiency of iron, folate, and vitamin B12 may result in anemia. The A beta lipoproteinemia is a very rare disease, and it is an inherited condition. The beta lipoproteinemia is a word that sometimes students are confused, but during protein electrophoresis, the lipoproteins they form beta or alpha bands. So here the proteins that form the beta bands on protein electrophoresis, when they are deficient, then we call this condition as the A beta lipoproteinemia. This is a genetically inherited disorder, and here what happens that this is an example of the failure of the transepithelial transport. I said in my last lecture of malabsorptive diarrhea that in malabsorption the defect may either lie in the luminal digestion of the nutrients, the defect may lie in the terminal hydrolysis or terminal digestion of the nutrients, or it may lie in the transport of nutrients across the cells. So the A beta lipoproteinemia is an example of the transepithelial transport defect. We know that the fats are broken down into triglycerides and glycerols, and when they enter the enterocytes, they are reassembled into the lipoproteins, and this is the lipoprotein form in which the fats are carried in the blood because they are insoluble in water. So in this type of disorder, there is deficiency of the apolipoproteins B48 and B100, and the presence of these apolipoproteins is a must for the formation of lipoproteins because it makes the lipoproteins, it makes the possibility for the lipoproteins to be carried in the blood. Because the protein portion, that is the outer portion of the lipoprotein, is hydrophilic. So the A beta lipoproteinemia is caused by mutation in the gene known as the microsomal triglyceride transfer protein. And deficiency of this gene will result in deficiency of the apolipoprotein, particularly B48 and B100, which are very important. Particularly the B100 is strongly associated in LDL particles with atherosclerosis, which can lead to conditions like myocardial infarction, peripheral vascular diseases, and atherosclerosis. And these apolipoproteins are used in the synthesis and exportation of the chylomicrons from the enterocytes into the blood. So what happens that a genetic deficiency of these apolipoproteins will result in failure of the transport of chylomicrons and V very low density lipoproteins respectively. So what happens that the triglycerides, they are retained in the enterocytes, not transported into the blood in the lipoprotein form, and they will present here as the large lipid vacuoles in the cells. We know that the cell membrane of every cell, it is made up of lipid bilayer. So a defective membranes which result from deficiency in the lipid component of the cell membrane will result in altered membranes of the cells. And particularly if we talk about the red blood cells, so the red blood cells, they are abnormal and they are known as acanthocytes and also known as the Barr cells. The irritable bowel syndrome sometimes is a cause of malabsorption, and very little is known about the actual pathophysiology that happens in the irritable bowel syndrome, and the diagnosis of irritable bowel syndrome is totally made on the sign and symptoms, because the intestinal histology, it is normal. There is no histopathologic changes or gross changes that can be seen in the intestines. So it is said to be a functional disorder without any gross or microscopic pathology in the intestine. It is said that this disorder results from the visceral hypersensitivity. The sensory nerve endings that are normally located in the intestine, they become hypersensitive. And this can be caused by certain diets and certain forms of psychological disorders like stress, anxiety, depression, and there are individual variations. Some people may get other triggers, but the problem results from the visceral hypersensitivity. The sensory nerve endings in the intestinal wall, they are hypersensitive to stress. For example, if they are stretched, they show a hypersensitivity response and cause spasm of the intestine. Moreover, the presence of short-chain carbohydrates, which are the fermentation products of the disaccharides, lactose and sucrose, which are fermented by the intestinal bacteria into gases like methane, hydrogen, and carbon dioxide, they may cause abnormal bowel motility. So here, as I said, that the intestinal mucosa, due to increased hypersensitivity of the sensory nerve endings, shows an exaggerated response, which may result in abdominal pain, and this person mostly suffers from constipation alternating with diarrhea, and sometimes the patient may present with other symptoms. The common symptoms described by the patients of irritable bowel syndrome include abdominal pain, bloating, diarrhea alternating with constipation, flatulence, nauseated feeling, loss of appetite, and sometimes the patient may suffer from headache, anxiety, and backache. The treatment of irritable bowel syndrome is purely symptomatic. Modification of diet that can be well made by the patient himself, and to avoid diets that contain short chain carbohydrates, for example apples, beans, and cauliflower. And in these patients, For the problem of constipation, we can use high fiber diet and sometimes stool softeners, and in severe cases, we may use osmotic laxatives. For spasm and pain, we may use drugs like serotonin antagonists and antimuscarinic drugs that will help diarrhea. The stress, anxiety, and depressions are accordingly treated best by a psychologist and psychiatrist, and this may help improve the symptoms of the irritable bowel syndrome. Microscopic colitis, microscopic, by that we mean that there is no gross change, but the changes, they are microscopic in nature. And microscopic colitis describes inflammation of the large intestine. And there are two types of microscopic colitis. One is the collagenous colitis, which is characterized by dense subepithelial collagen layer. We know that the intestinal layer contains mucosa, submucosa, muscularis mucosa, and serosa. And particularly the mucosa, which is composed of epithelial cells and the lamina propria and the surrounding muscularis mucosa. So there is excess infiltration of the subepithelial collagen layer in the lamina propria. Sometimes there may be infiltration of some inflammatory cells, particularly the lymphocytes. In the two types, the major difference there is that, as clear by their names, in collagenous colitis there is excess collagenous tissue, while in lymphocytic colitis the collagenous tissue may be normal, but there is high intraepithelial infiltration of the lymphocytes. The exact cause of these diseases are not known, but theoretically, since these are associated with other autoimmune diseases, so they may have an autoimmune uh, origin. However, it is a study topic, and other factors may also be involved. And the major problem in microscopic colitis, usually it is diarrhea and malabsorption. The diagnosis is only microscopic histopathologic examination of the intestinal wall, which may show either excess collagen in the lamina propria, or it may show uh, excessive lymphocytic infiltration in the subepithelial regions. Under the microscope, the collagenous colitis will show excess collagen accumulation, while the microscopic colitis may show high lymphocytic infiltration. The To make a summary, lactase deficiency or lactose intolerance will cause osmotic diarrhea. In irritable bowel syndrome, there may be individual may suffer from different symptoms, and they may present with different symptoms, particularly the chronic relapsing abdominal pain, bloating, and changes in the bowel habits. And it is a functional disorder in which we cannot find out any gross uh, or microscopic pathology. The collagenous colitis is characterized by the accumulation of excess collagenous tissue in the lamina propria of the uh, intestinal mucosa, while in lymphocytic colitis, uh, there may be excess lymphocytic infiltration, and both of these conditions may cause chronic watery diarrhea. Thank you very much.